Good afternoon. I am Maya with TMC for Seniors, and today we are discussing peripheral arterial disease with Dr. Robert Fincher. Dr. Fincher is with Pima Heart Vascular. He has been with Pima Heart for about 6 years, and he is a vascular surgeon. As you can tell today, he's actually has a few more cases going on this afternoon once we finish up. So, welcome, Dr. Fincher.
Thanks, Maya. I appreciate it. With that, I'm just going to start right into the talk. Today, I'll be talking about peripheral arterial disease. So the goals of this talk are, one, just define what peripheral arterial disease is, define risk factors, and explain how risk factor modification can help with the treatment of peripheral arterial disease, and identify and explain treatment options to include medical management and then surgery. So what's peripheral arterial disease? It's really a narrowing in the arteries that supplies the blood vessels to the extremities. And once that narrowing gets severe enough, it can cause pain when you walk, it can cause pain when you're resting, that's usually in your toes, and wounds that do not heal because of the lack of the blood flow to those wounds. So I'd like to go into talking about pain with walking just a little bit more. When you're a vascular surgeon, we call this intermittent claudication. You'll hear that term frequently, and that's a big fancy word for limping. Limping when you walk. Claudication means to limp in Latin. So we like to talk about intermittent claudication and how that affects lifestyle. Intermittent claudication can occur at long and short distances, and that limp occurs in a reproducible manner every time you walk. So at specific distance, you will feel pain in your calves or your thighs. What claudication is not is pain in your calves or thighs when you're at rest, or crampy pain. All of those things are not associated with PAD and intermittent claudication, and are more associated with different medical conditions and electrolyte imbalances. PAD can also cause pain at rest. And if the vascular compromise is severe enough, or the oxygenation to the tissues is inadequate to support normal maintenance and physiology, you can get pain. You can also get wounds that will develop, and then they won't heal. So this is just a graphic illustration of how those arteries become narrowed. Inflammation in the vessels causes a buildup of fat in the vessel wall. And as that fat accumulates, it remodels into a plaque that can ultimately narrow or even result in vascular blockage. So risk factors associated with peripheral arterial disease include advanced age, your race, male gender, smoking, diabetes, high blood pressure, high cholesterol. And the last two that I'm not really going to touch on are renal insufficiency, which can lead to a buildup of calcification in the vessel walls and blockage, and then some rare clotting disorders. Those are something you can talk with your primary care physician about, but today it's a little beyond the scope of our talk. So I'm going to go into those risk factors now and just kind of look at them. So as we age, each decade of life that you add, there's a 1.5 to 2-fold increase in peripheral arterial disease. So as we age, it's the normal aging process that the pipes get clogged, unfortunately. The next risk factor I want to touch on is just race. In our community, especially Hispanic race is associated with an increased risk of diabetes as well as PAD. African American, specifically women, are at increased risk of peripheral arterial disease. And the old adage that everyone's created equal holds true, but risk factors for disease, unfortunately, are not equal among everyone. Another big factor that we see quite frequently is smoking. This is the biggest risk factor associated with PAD, and it's not just limited to the peripheral vasculature, but can also affect vessels supplying your heart and your brain. With diabetes, that's another one I see quite frequently in clinic. And that little number, hemoglobin A1C, that everyone is so interested in, for every 1% increase in that hemoglobin A1C, that's associated with a third of an increase in your risk of developing or having PAD. So that number becomes very important, and current ADA guidelines recommend that that little number needs to be less than 7, with the caveat that you avoid significant hypoglycemia or low blood sugars when you achieve that. Next risk factor I want to touch on is high blood pressure. That can lead to increased risk of PAD, as well as stroke, coronary artery disease, heart failure, and problems with your kidneys, or what we call chronic renal insufficiency. The goals for people who have PAD, we'd like to see their pressure under 140 systolic or 90 diastolic, the top and bottom numbers. If you have diabetes or renal insufficiency, we want that a little bit lower at 130 over 80. The treatment of this, with patients with PAD, ACE inhibitors should always be first line, and that's something you can kind of talk about with your primary care physician as well. These are your lisinoprils, your ramiprils, as those have been shown to have beneficial effects for your kidneys, as well as inflammation in the blood vessels. The next big risk factor is high cholesterol. And people often ask me, I don't have high cholesterol. I have peripheral arterial disease. Why should I take medication? So, current American College of Cardiology and American Heart Association guidelines recommend that LDL goal should be below 100, and if you have diabetes, it should be less than 70. There's an independent benefit from using statins in people who have vascular blockage because it lowers the inflammation and it stabilizes the plaque in your vessels. So the progression of disease can somewhat be halted with statins. Like I said, it'll stabilize the plaque, it'll reduce inflammation. The thing it won't do, and I get this question frequently, is it's not going to reverse the blockages or narrowing. That's something that can only be treated with surgery if it's severe enough to need surgery. So when you come to a vascular surgeon, frequently you're going to want to know how we're going to diagnose this condition. People come in very concerned that their blood vessels are blocked, they're having problems with their legs, and they want to know, is this the arteries or is this something else? So the first thing we're going to do is sit down with you. We're going to ask you specific questions about your risk factors for development of PAD. Have you had a heart attack? Have you had a stroke? Do you have diabetes or high cholesterol? Do you smoke? All of those questions will be very important. And then we're going to do a thorough physical exam. We're going to check and make sure you have palpable pulses in your feet and your extremities. We're going to check and make sure the capillary refill, or when your toe turns from white to pink, that's short 2 seconds or less. And then we're going to look at your extremities and see if you have any mottling, skin changes, or wounds on your feet. Other thing that we'll frequently use is a quality of life questionnaire that specifically addresses how you walk and what impact your inability to walk has on your life. It's pretty quick. It's designed to assess the impact of claudication on your life. That's another tool we may use in our clinic to help diagnose this and how it impacts your life. The next phase after we examine you will be testing. And typically we use non-invasive testing, but we can order CT scans as well. But the mainstay of what we'll do in our clinic is ABIs and ultrasounds. And an ultrasound is just a quick way to snap a probe on your leg and look at your vessels using sound waves. So the first test we typically run just to diagnose PAD is the ankle brachial index. And what we do is we look at the pressure in your arm and the pressure at your ankle, and it's an excellent screening tool that can be used in primary care physicians' offices as well. So you can quickly determine if you have a high risk of PAD or even if you need to see a vascular surgeon. So just like I was saying, what we typically do, we check the blood flow in your arm with a blood pressure cuff up, and at your ankle, we look down at your ankle and listen to the sound, and we compare those two. And that's going to give us a really excellent idea of how severe your disease is, or even if you have it. So our little interpretation scale, a normal ABI is between 1 and 1.3. Above 1.3, vessels become non-compressible. People can have very calcified vessels, but if they're very calcified but still have good blood flowing through them, that's fine. It doesn't mean you have blockage. When we really get concerned is when the ABIs drop below 0.4. And that's where we see some really significant problems with inability to heal wounds and pain in your feet at rest from vascular blockages. Again, looking at an ultrasound, it's pretty quick and easy. It's non-invasive, doesn't hurt. All we're going to do is we look at the blood flowing through, and we look at the waves that the sound makes as it comes back to the probe, and that can tell us where blood vessels are narrowed and if they're narrowed. So once we get a picture of what's going on in your blood vessels, then we can move into treatment of peripheral arterial disease. There's medical treatment, and typically aspirin is something we give to everybody. So with the diagnosis of PAD, everybody's going to get aspirin, and this inhibits platelet aggregation, as you know, and it has an independent benefit with heart and stroke risk as well. Again, lowering that platelet aggregation is going to be important to prevent those blockages or narrowing from becoming blockages. Again, just going into medical treatment, everyone's going to be on aspirin. Statin is also the next line. If you have PAD, we're going to give you that statin, whether you have high cholesterol or normal cholesterol, so it stabilizes those plaque and lowers inflammation in your blood vessels. The other thing, if people claudicate, as we discussed, or limp when they walk, we may try cilostazol. And that's a medication that lowers the viscosity of the blood and gives you an increased ability to walk farther than you normally would. There's some minor side effects with this, and it's we can't use it in patients with heart failure. So that's the big thing, but that would be first line for medical treatment. There's other different medical treatments as well that you may be prescribed other agents. So this is not all inclusive, but it's an excellent start. Trentol is another agent that's typically used. That's an older agent. Again, lowers the viscosity of the blood. We see that frequently. Going into treatment now, from medical treatment, there's kind of an in-between surgery and medical treatment with medications. What we call that is a supervised exercise program. So this is a physician prescribed exercise program where we push you to walk until you feel the pain in your legs from the narrowing in your arteries. Once that occurs, you rest, and then we push you again. This typically occurs 3 to 4 times a week, and the results of supervised exercise treatment are almost the same as what you would find if we performed surgery in people who limp. So we've had really good results with this, and it avoids surgery, which everybody unfortunately wants to avoid, or fortunately. So the next thing I just want to touch on just a little bit is surgical treatment. So now in vascular surgery, things are done with a minimally invasive impact to your life. We want to get you in and out of the hospital and back walking and doing your normal activities with minimal impact to your life. Whether that means we're revascularizing your legs or improving your blood flow for claudication or for wounds, we're going to try and get you in and out of the hospital as quickly as possible. So again, endovascular therapy is where we go in with wires and catheters into your blood vessels in a minimally invasive manner, and we take pictures with what's known as angiography. And then we can balloon blockages with what's known as angioplasty. We can open up those blockages with a stent. And then the last thing is a little roto-rooter device called an atherectomy device. So again, just an illustration here of, how endovascular surgery really works. This is somebody's aorta right here. You can see the two arteries coming out of the aorta are significantly blocked right there. This was a patient who couldn't walk to get their mail, had significant problems with doing anything. Their quality of life was significantly impacted. Again, we went up with wires, catheters, got balloons through there, and then you can see that little cage. That's a stent. And that cage opens up the blood flow, and now you can see that there's blockages have gone away. And so, this patient told me that she hadn't been able to get her mail, and after her procedure, she went to Costco and walked around the entire store without taking a break for her whole shopping experience. And that may not sound like a big deal, but it was really a very large deal for somebody to go from not wanting to leave their living room to walking around a store with no pain is really, our goal is to restore your quality of life. And then the last thing is, if we can't treat stuff with endovascular means, we can do open surgery. And what that really entails is opening up the arteries and either cleaning them out and patching them or performing bypass surgery. Again, another example of that, this was a patient who had pain in their feet at rest. And what we did is, you can see this large dark line coming down and then this little tiny line coming down right here. That was the native vessel. We plugged a bypass in there. What we did was we were able to take blood flow from the artery, as you can see up here, and we ran that all the way down to the foot, to that little artery right there, and got that patient out of rest pain. So with that, I'd like to talk a little bit about the treatment and what that means and how that relationship is developed between a patient and a vascular surgeon. I don't offer the latest and greatest technique to every single patient that comes through the door. The best technology may be old school open surgery. So we're always going to tailor the treatment to the patient. Again, surgery is a decision between you and your surgeon, and it's not unilateral. I had a patient come to clinic the other day and said, when I asked them if they wanted surgery, they said, "I don't think I have a choice." And that was the most disheartening thing to me, because it means that I didn't educate that patient on what was going on in their blood vessels, and I didn't give them that choice. So if you consent to surgery, and it doesn't matter if you see me or another vascular surgeon, that means you make an informed decision together and decide on a treatment that best suits you after you've considered all the risks, benefits, and alternatives. Unfortunately, surgery has risks with it, and some of those risks can be serious. So before you undertake anything, especially in my practice, we sit down and we talk about what it means to undergo surgery and what you can expect. The last thing I wanted to talk about a little bit is PAD prevention. You can't stop aging. Genetics is something you're not going to be able to avoid, unfortunately. And the things that you can control, what I'd like to do is just look at those. One, smoking cessation. Aggressive smoking cessation can really, really help with, limiting that progression of peripheral arterial disease. Exercise, again, pushing yourself. Supervised exercise programs have been shown to be nearly equivalent to surgery and surgical management. So it's important that people get out there and stay active. Diet is also very important. We know that eating red meat, beef, things like that, not leafy green vegetables and fruit, is a diet that's, the meat and potatoes diet should be avoided if at all possible. And then the last thing is just stress. Do those activities that lower your stress level, because stress can lead to many different things: inflammation in vessels, high blood pressure, all of those things. And with that, I'd like to conclude my talk on peripheral arterial disease and open up the floor to Maya for any questions.
Yeah, thank you, Dr. Fincher. I do have some questions. One of the questions that came in asked about the difference between PAD and neuropathy.
That's an excellent question. We get that quite a bit. So PAD in a very advanced stage can cause problems with neuropathy, but 99% of the time, we're going to see that neuropathy is caused by problems with the back, diabetes, or peripheral neuropathy of unknown cause. So that's an excellent question. It's one we get all the time and I see in clinic frequently. We are going to do due diligence when you come in, and we'll evaluate your arteries, so we know that neuropathy is not caused by peripheral arterial disease.
Okay, and also, I guess sort of in a related question would be, what about PAD versus varicose veins?
Excellent question as well. So, blood flow to your feet is carried in the arteries. Blood flowing away from your feet is carried in the veins. So I frequently get that question. People are concerned that they're going to have problems because of varicose veins. Those are not related. Varicose vein treatment is another topic in and of itself, which we as vascular surgeons treat as well. However, in this discussion, venous insufficiency and PAD are distinct entities. Like I said, one is blockage in the arteries, and the other is two-way blood flow in veins.
Okay, great. Now, if you were having symptoms, how quickly should you be seen?
So it depends on the symptoms. If you're having pain in your feet and the feet are cold and you're getting numbness or tingling in your feet, then that's something that needs more urgent consultation. If you are having pain when you walk, then that's something that needs less urgent consultation, but should still be addressed.
Okay. And what about if you are seeing maybe a podiatrist? Would you also have a need to see somebody for the vascular side of things as well?
That's an excellent question as well. So, the podiatry and vascular surgery work hand in hand to care for patients who have wounds on their feet. So if you have wounds on your feet, most likely you're going to see a vascular surgeon for an evaluation of the arteries to make sure you can heal those wounds. 90% of the time, you're going to have adequate blood flow to heal those wounds. However, if you don't have adequate blood flow to heal those wounds, that's where we can step in and help improve the blood flow so that you can heal those wounds.
Okay, wonderful. Now, if you are having redness and heat in the feet, and that's a symptom of PAD, or would that not be a symptom of PAD?
It usually is not a symptom of PAD. Redness in the feet can be a symptom of PAD, but redness and heat, typically we see that with venous insufficiency or people who have problems with their veins.
Okay, that's great to know. I know it seems so minute, the differences and the details. Are there any exercises that you recommend, or what are the best exercises for somebody who may have PAD? I know you mentioned that exercise was extremely important. Of course, there were lots of things on your list.
Yeah.
Don't be stressed, and
Yeah.
which I know is really hard right now.
I know.
What can we do about exercise?
So exercise, as long as you're walking, get out and walk is the big one. That's what I always tell people. How far can you walk? And I'll ask those specific questions in clinic. How far can you walk? A lot of people say, well, I don't walk very much. Well, if you don't walk very much, then that's really not contributing to helping with peripheral arterial disease. And as you know, people who get older, the older you get, the more you're going to be at risk for developing PAD. So the more you can exercise, the better off you'll be, because what happens is little collateral channels develop around blockages. And with all that collateralization, that really keeps you walking those distances that you want to.
Great. And I just want to wrap up, Dr. Fincher. And if somebody wanted to make an appointment, I am going to put the phone number up here on the screen for Pima Heart and Vascular.
That's true.
It is 520-838-3540. So they can certainly call to make an appointment if they have questions and they want to be seen for anything that might be PAD related. So I think it looks like I think I've covered all the questions that came in today, and I appreciate you taking the time. It was a great presentation. You provided us a lot of information. So thank you so much for being here.
Thank you for having me, Maya. I really appreciate it. So we have 7 vascular surgeons in our practice, and I'm not the only person there. So we can get you in, and if you want to schedule an appointment, we have a ton of people who are interested in seeing you.
Excellent. And I know you have locations throughout Tucson as well. So there's several locations.
Yeah.
Thank you again.
Thanks so much, Maya. I appreciate it.